Good morning, everyone. Myself, Sridevi of Assistant Professor, Malla Reddy College of Pharmacy, cordially invite you all to the fifth day of Faculty Development Program on Enhancing Faculty Expertise in Pharmaceutical Sciences and Clinical Education. I request our Principal, Sir Dr. N. Sudhakar, Sir, to please speak few words regarding today's session.
Good morning, all. Welcome to the fifth day's FTP session. Thank you all the participants, those are all attending all over India. Very good response from all the participants. Uh, Today is the last day, of course, and today is about the oncology and completely related to the immunotherapy and novel therapeutics. I think this topic is related to all fields of the pharmacy. So our faculty, Dr. Prakash, is going to deliver a good lecture. So all of you, please participate and raise the questions in the text box so that he can answer. Thank you very much. Please proceed.
Thank you, sir. It adds me an immense pleasure to introduce our today's speaker, Dr. PDSS Prakash, Associate Professor of Malla Reddy College of Pharmacy. Dr. PDSS Prakash has completed his PharmD in 2015. Following this, he worked as an associate intern at Kalaga Herbal Research Labs until 2016. He briefly served as a floater pharmacist before transitioning into an academic since 2018. Dr. Prakash has been a faculty member teaching pathophysiology and pharmacotherapeutics to PharmD students. He has also guided multiple research projects and mentored 6 year interns. He has been actively publishing research findings in relevance to the changing landscapes in pharmacy practice. Now, I would like to request you, sir, to commence the session.
Good morning, everyone. So, I would like to heartily welcome you all for this FTP program. And today's topic is going to be the most contemporary concern in this real time world. So, that is the focus will be greater on an oncology landscape. And if we look into the cancer, we might see as a benign one and also we might see as a malignant one. But in this current times, we have been looking into more intrinsic details of cancer researches. Since we know how a cancer is being treated, now we are going to delve into the new technologies emanating into the current society. Hence, my today's topic is architecting the future of precision oncology. And in that one, so we are going to look advancing cancer immunotherapy. So that is focusing on the patient's profile through comprehensive immune parameters, and also we have to apply the novel therapeutic instincts. So we'll proceed with my first gesture. So now coming into the oncology, as we always know, oncology is nothing but how we are going to see the pathological changes that happens with the cancer, and also we would examine how the normal cells would be differentiating to the cancer cells. But whereas in this case, in a recent trends, we have been looking into this aspect called as a precision oncology. So when we are coming to the word precision, so that means we have been much more into the profile of the patient rather than the population of the disease. So that means if you are taking a cancer patient, you are examining the tumor profile of that particular patient, and thereafter you are going to assess what kind of treatment approach is going to be beneficial. And this is a new kind of trend that has been emerging. So let's dive into the concept. In case of precision oncology, we can observe this molecular profiling of tumors is going to be the most important aspect so that you can identify a targetable alterations. Hence, we are being academicians, we would probably know how this cancer is going to develop. We know the molecular pathways very well, and we do also know whenever in particular anatomical location a tumor might develop, it may be a benign one, and also it may later turn into a malignant one. So such kind of transformations might be possible. So those would be usually called as a hallmarks of cancer. Since the hallmarks of cancer had been detailed, we have been looking into the new aspects that are introducing into the hallmarks. So here we are going to see if a cancer patient is being treated, you are going to investigate the genetic profile and as well as a molecular characteristics. And that is a new trend being coming upon. It's called a personalized treatment plans. So when we are coming into this genetic and molecular profiles, that is being more specific towards the cancer patient, so that you can reduce the burden of adverse effects and also you can improve the treatment outcomes. So what we believe to be a rational therapy is maximizing the therapeutic effect, and also we would not want the patient to be suffering both economically and as well as physiologically. So that would be the main agenda, and also in case we would want the patient to have a good survival rate. So all these factors will be pouring into the precision oncology considerations. So let's go into deeper senses. Let's talk about the aspects of this precision oncology. The first thing, as we have said, molecular profiling. So here we have to examine the molecular profile of the tumor. So as we see, you have to look into the genetic aspects, the genomic considerations, and proteomic features of the tumor. And next thing, if you are going to look into the therapies, that is being called as a targeted therapy. So your agenda is to have your therapy focused on the molecular targets. So you are going to make a stratification details of the tumor, and then you are going to make an assessment. Okay, based on this tumor profile, this is going to be the most impactful therapy. And biomarker driven treatment selection. So you might have known, usually when we talk about the biomarkers, they are used for identification of pathogenesis, to how much degree the disease might have progressed. And this would be rather helpful even with the treatment choices in cancer. And next thing is, you're going to integrate a plethora of the data. So in the current trends, we have been looking into this data science. So we have been using the data, we are piling up a huge amount of data, and we are going to make a very particular architecture of the data, so that we would know you have a algorithm focused on the data, and that would be giving out the results. So which one would be more conducive? So here you are going to use the data of genomics, transcriptomics, proteomics, and metabolomics. All these together are going to necessitate further development of this oncology immunotherapy. And next thing, and the finalized thing would be a personalized treatment plan. So that's what we are saying. Whenever we talk about immunotherapy, it is patient profile specific rather than a clinical condition. So this is a brief denotion of this immune profiling. So here we are going to say about immune profiling. So you have to understand the immune signatures. That means again we will get into those old details. If one would be developing a tumor, obviously your immune system might be able to attack it and it may bring it under control. But where we would be seeing any kind of differences, or we can say the immune system might not be able to deal with such kind of tumor. So those questions could be answered using these kind of immune profile technologies. So and also we have seen a particular single cell immune profiling. So that is nothing but, when we talk about a tumor might grow and it can travel, and it may relocate to some other region where it is going to find very much feasible to grow. So what happens? The secondary tumor which might grow is obviously going to outshine the primary tumor also, so that it can become more aggressive, and also it may disseminate and travel to other regions of the body. So at that certain point of time, you might think about a question: if a tumor could grow very well at another region, how come only at that region? So what are the specifications which is actually making it favorable? So that is nothing but, we usually call it as a tumor microenvironment. So where you can see that it is finding all the relating parameters and all the favorable conditions to grow. So this is what we speak about tumor microenvironment. So that kind of environment is usually going to evade the immune system. So what happens? Your immune responses might be correct, but if that is being directed at the tumor where it has its dominion capacity, at that region, the immune cells might be futile. they might not be able to do their work as they were intended to do so. So those kind of parameters are of vital importance. So here we are going to see in oncological terms how there has been a shift in these parameters. So what made them unique in order to identify a particular cancer set and assessment of the patient. So here we have been saying about genome profiles. Since genome profiles, we would always know what makes a difference between a normal cell to that of a cancer cell is nothing but it does not have control over its proliferation. And also, there is no regulation in its cell cycle. So that's what here you're going to observe. Is there any kind of a gene alterations that usually may occur due to mutations? We all know the most common kind of mutation that may leading would be a point mutation. And also you can able to see a change in copy numbers and also the chromosomal rearrangements. As we would also know better, we have a chromosome set. So you have a fragment, and if that has been translocated to other chromosome, then its functionality is going to decline. And second thing, it may become aggressive in cell cycle function. And other parameter we would be looking out is transcriptomics. Here we are going to see how the gene expression patterns would be changing. So what is the point where there is a dysregulation happened? So based on that aspects, you are going to target the therapeutic possibilities. And proteomics, from the word you can understand proteo. So as we are speaking of proteins, you're going to analyze a protein expressions because we say a transcription and translation. Here the genetic material is a main raw material for that to happen. So here you can see this protein expression analysis, and also once if the translation has happened, if there were any kind of a defects which would be leading to such implications. And metabolomics. So as we are seeing metabolic signatures in cancer cells, that means if you would examine a cancer cell to that of a normal cell, you might be even seeing any activity that is going to be way different than a normal cell. So here the cell survival for a longer period of time, the cell functionality. So all these metabolic signatures are going to be quite independent. So if you take a normal cell, it has a life period. So after a repeated cycles, it might come to an end, but it does not happen in case of a cancer cell. So that's what it makes it unique. It's going to escape the death signals. So it is going to evade the apoptosis signals. All those signals which are condemning it to grow, so those are usually being evaded by the cancer cells, and it would be taking the level of immortality. So hence it had remained a concern. And immunoprofiling, so as we are speaking of this one being more relevant to our topic, so here we are saying that main changes have been happening with the tumor microenvironment and also with the immune cell populations. So these changes and these implementations are quite necessary in order to make the immunotherapy successful. And pharmacogenomics, as we have seen, genomics. So that means here, if you have been part of that study where you have been using a pharmaceutical agent, here you have to understand a genetic factors would also come into the role if you have been treating such kind of complex conditions, whether how they are being influenced with the drug action. So that is nothing but you would examine a drug response, and also you're going to see into the toxicities. So based on the weightage of the toxicities and also the rationality towards working of a drug, you're going to assess the particular therapeutic tailoring needs. So that would happen in case if pharmacogenomics is widely studied. So it is helpful in the dosing and as well as selection aspects. And next thing, here we say that biomarkers are going to be having a very distinctive role. So here what happens is the biomarkers not only going to denote the pathological concept, but also are going to show, or we can say denoting an immunotherapy responses, if that is being okay, or else if that would be remaining under subtherapeutic response, or would there be any requirement of a combination? Is there going to be any synergistic response if that had been added to chemotherapeutic agent? So all these kind of considerations would be helpful if biomarkers are studied well. So particularly we would usually see PDL1, so that has been the most common method. So PDL1 expression, so that will be usually done through immunohistochemistry. So what happens is you're going to look onto those biomarker signatures, so particularly onto a tumor or onto an immune cell. So what happens is, in this case, FDA had approved many things, but the problem occurs is with the heterogeneous expression. I would say this is a very primary concern, a heterogeneous expression, and those have been with this biochemistry and in molecular biology, these kind of words are a usually common thing. So one thing is heterogeneous expression is going to be a hindrance factor, and second thing is dynamic regulations. So all these are going to be having an impact through variable cutoffs. So that means if you would say that if it is being a standard one, or else if it is going to make it more generalized approach to examine, I would say generalized one. So that's what here we have been saying. There is a thing called as a combined positive score. So based on scoring is nothing but you're going to assess the conditions where you're going to look both tumor and immune cell expression of PDL1. So in that one, what happens is you're going to check the assessment that is going to happen between the tumor and to the immune response. And second thing we are going to look out is tumor mutational burden. So that means when we say about a tumor mutational burden, so from the word you can understand, if we are going to dissect the words tumor and mutational burden. So that means you are going to see if a mutations are going to happening. And if those mutations are non-synonymous, so it's not a repetition that is going to happen, but a different sets are going to be present. And if there are such kind of numbers present at the genome set. So the kind of methodology we are going to observe is whole exome sequencing or targeted panels. So we will be having a threshold value. So where up to a certain extent, you would say that it is being okay. So that's certain extent you're going to look is 10 mutations per MB. So that means if anything beyond this 10 mutations per MB, so for that kind of tumor response, you're going to be seeing a pembrolizumab. So this is the most, I would say, heard drug, pembrolizumab. And if you're going to administer the drug, so based on these considerations, there are certain challenges because, like, unless like an immunoassay, here we see that the predictability might not be always a correction one. So you might see any differences may happen. So here we are going to see the challenges are observed are a standardization of assays and cutoffs are going to be different for different kind of cancers. So here this indication does not being a constant for all kind of cancers. So as you come up with each and every different kind of a cancer, usually the scoring factor would also going to be different. So such changes you might be able to see in another parameter called as a microsatellite instability. So when we are talking about this microsatellite instability, so these are nothing but here you are going to test for the protein factor considerations. So that means we are saying that whenever this cell regulation is not being in constant, obviously we are going to attribute the changes to the gene expression. So if gene expression had been misunderstood by the immune system, you are going to see these are all the disturbances that are going to happen. So we are going to see microsatellite instability and as well as deficient mismatching repair. So all these are going to be mismatch repair proteins are going to be identified. So from the word you can understand mismatch repair. So in that aspects, you're going to see a mismatch has happened. So instead of being corrected with the damage of the DNA damage, it would have turned to a different way. So that mismatches would also cause an error. So if that error prones to the cell cycle, obviously the products of the cell cycle is going to give off many errors. That is an exponential of errors. Those errors are nothing but cell products. That would usually make the tumor more aggressive. So that one we would be able to see. And when we are talking about particularly in this kind of microsatellite responses, you might see this is a pan-cancer biomarker. Obviously, we would know from the word pan-cancer. So unlike the previous one, here we can say that it is going to attribute changes for all kind of cancer immunotherapy responses. So here you can measure. It does not have a differentiating value for different kind of cancer. it would usually remain the same, and it is giving an indicative parameters whether the immunotherapy response is going to be a standard one. So this is most commonly being used in case of colorectal cancers and endometrial cancers. Like when we talk about cancers, these kind of concepts are usually much more in depth. So in a recent trends, we have seen if somebody has a colorectal cancer, particularly to say, they've said that the people who have an excess amount of fat in the liver, so that's condition is being called fatty liver, right? So if that fatty liver has been in a greater levels, so the rectal cancer has a chance for a greater metastasis. I know it's not believable kind of a thing, but this was a new indication which was given. So all this kind of what I meant to say is physiological relations have been there. So in this case, you might be able to see a high neoantigen load. So due to accumulation of mutations, as we know, new antigen. So here you are identifying a set, so which has not to be happening, because once we understand about an antigen, we usually remind of a thing called like bacteria, a product of a bacteria. So that means here we are saying a component or a fragment to be called antigen. But here the antigen would be denoted not of any kind of a microbial, but an undesired product. So that means that would be considered like a foreigner. So this we would be mentioning as a high and neoantigen load. So this would be usually greater because of accumulation of mutations. So that means like, dumping of more and more dysfunctional or dysregulational cells. So that would be putting out more and more transcription and translational factors. It would be pushing to a greater level. So these accumulations might happen. And other thing you're going to see is tumor infiltration lymphocytes. So when we are talking about the lymphocytes, because when we would look into the immunotherapy, the main focus will be there on lymphocytes. So we would not see an antibodies, but we would see a T cells to be having an active role other than natural killer cells towards the immune functioning. So here you are going to observe histological evaluation. So that is all through digital pathology algorithms. So due to the limited constraints of our time, like not be able to bring a high level of picture in that. So here we can just understand an outline how this tumor infiltrating lymphocytes. So this one here it is going to denote if infiltrating lymphocytes are to be at a greater level. So that means the immunotherapy had been working very well, because we see what happens with a lymphocytes deficiency. Since these have been required for such chronic conditions, such powerful conditions, we want them to be in a very intense situation. So here, if they have been present in such kind of intense situations, obviously your immune system is firing very well. So you are particularly going to see about CD8 cells, so that which are being more required for anti-tumor activities. So all these kind of analysis have been done. So that is within the tumors, and you are going to check for this gene expression profiles. So particularly when we talk about this T cells, so when we are going to say about these T cells, so particularly this interferon signatures, because when we talk about inflammatory conditions to happen, so inflammatory conditions are usually we usually see a mediators of both pro-inflammatory and as well as anti-inflammatory. So that means here we say that particularly if you want the T cells to be functioning very well, obviously what role would they play? So you can see that in these cases T cells would be having a pro-inflammatory effect, so the responses would be more like a damaging one. So here you are going to observe this GEP, that is nothing but gene expression profile. So this T cells, as we have said, that these are going to be flaring. So obviously it is a pro-inflammatory responses, and so does you are going to see interferon gamma signature would be there. So always when we think about an inflammation, we say that we have TNF alpha, transforming growth factor beta, and interferon gamma. So alpha and gamma are being pro and beta is being anti. So these kind of platforms would be usually required are a nanostring encounter and RNA sequencing techniques. RNA sequencing is the most known kind of a methodology, so that would have been performed. So these kind of tumor infiltrating lymphocytes had a better understanding, so where they have been showing a good response. For that reason, they have been brought into different kind of measurement activities amongst many cancers. So the advantage here it is going to capture an immune interactions. So instead of a single marker, so instead of having a profile of a single marker and observing the immune responses, this one is going to have a whole different level of observation. So that is many different kind of immune mediators. So they are coming against the cancer and they are interacting with it. Such kind of complex interactions could be observed by this tumor infiltrating lymphocytes assessment. And next thing, other thing is ctDNA. So as we are mentioning, like circulating biomarkers, the word itself is going to simplify very well: circulating tumors DNA. So in this kind of change here, you are going to observe how much the tumor burden had been, because we know in case of tumor, rapid proliferation of cells, so too many cells. So if too many cells are nothing but too many of genetic material, so as we are seeing, some would be coming against this apoptosis, but not many. But here you can able to observe the components, so that is nothing but how they are emerging well. So what you're going to observe, if this kind of changes are going to happen, you're going to see the immune system becomes activated, and you're going to look into the phenotyping aspects of mononuclear cells. Because if one would ask, what could the mononuclear cells would do? So mononuclear cells becomes macrophages. So, and after that, that is going to provocate an inflammatory response. So, the most common kind of responses we have seen is cytokines. So, as we can say, these are on a primary top notch list of inflammation and inflammatory response. Here we would be looking as a anti-tumor response to be happening. And so does here you are going to observe chemokines. So, chemokines are those nothing but which would be usually aiding the process of this pro-inflammatory responses. And also we are going to see soluble checkpoint molecules. So the checkpoints along the cell cycle would be taken into consideration. So the main advantage, it is being non-invasive, and you can have a repeated follow-ups of the values. So through the circulating biomarkers. I know it's a bit complex, but it's a most interesting that we have made a whole lot of changes in this research aspects of oncology. So this one is a very less known kind of thing. This is called as a gut microbiome analysis. So when we are talking about this gut microbiome analysis, so microbiome analysis would be usually having this 16S RNA sequencing. So here you are going to see any changes in the genomic profiling. So that would be usually observed. So how it would be usually observed? So it is not directly related, but here we can say that only particular if there is any bacterial species. So those are associated with immunotherapy responses. They have been looking into this gut microbiome analysis. So what could be the potential thing you're going to observe is microbiome modulation. So that we are going to look into a bit detail. And human leukocytic antigen genotype. So here we are saying that this HLA antigen. So that means we are going to see how HLA composition is being there. So it is labeled, and how the specific alleles are being there, and how they are linking to the immunotherapy outcomes. So all these are going to be very much helpful to know if your immune system, if they have been treated with this immunotherapy, whether it had been aided to tackle this tumor changes, or else it would also even denote any severities happening in immune related adverse effects. So all these are going to be there, and since we are saying that it is a complex topic, a lot of researches have been happening since a long time. So there is a specific data on certain kinds of cancers which is going to show a positive outcomes, and some have remained in uncertain phases. So coming to the historical perspectives. So here we can see, because since it is a new kind of topic that is being dealt with, but the main origins could be looked into the year 1960. So the main concerns have been shown towards chronic myeloid leukemia. So from there, here you can observe the Philadelphia chromosome. So that has been actually identified was, we can say, as pinpoint. So that is nothing but a starting pinpoint for this precision oncology. So what happens is if you are pinpointing the origin, so that too if a genetic profiling, obviously you would have a greater scope just to know the physiology, how the transition is going to happen. So usually when we come across this cancer growth, we would name a certain thing called as a anaplasia. So it's a degree of differentiation. So how the tumor has been differentiated, poorly differentiated or well differentiated. So when we talk about poorly differentiated and well differentiated, we see the things like, poorly differentiated and well differentiated. The words might be a little tricky. So that means here we can say that which one is dangerous and which one is not. So that means that depends upon how the changes have occurred to the normal cell, whether if it is retaining any much characteristics related to the normal cell, or else if it had transitioned to the tumor cell. And here you can able to observe this historical perspectives have started right from the 1960, and it had grown into the prospective years. And after that you can see the main changes have happened with the human genome project. So as we have speak in case of 1990s, and after that most of the diseases have been viewed in a different way till that date. And after that it had been denoted, okay, it's not just how the disease happens, it's not how the clinical manifestations are going to be evaluated, but at the molecular level. So how this disease is going to progress, and how any kind of a tissue, or else we would say any physiological system, how it is going to be transitioning from being normal to abnormal, how the function is being impeded, and how these morphological changes have been happening. So that is nothing but it had been a very good groundwork in understanding the genetic basis of the diseases. So particularly here we can see all these trials over to the genetic material research is going to be showing an FDA approval. So for this imatinib, so that is for chronic myeloid leukemia. So as we have seen that particularly it has begin the targeted therapy in oncology. So after that we have seen that endothelial growth factor receptor mutations have happened. So that means this happened to be indicators in order to know the mutation. So if that mutation has been happening, if you are going to give gefitinib, so that is nothing but in case of people who have been suffering with the non-small cell lung cancer. We would know a non-small cell lung cancer. It's not usually a normal one. So we would not see like any characteristic relevance with the age and also the smoking status, and it's a different one. And here at that certain point of time, the EGFR mutations, how they have been tackled with the this gefitinib drug. So that was nothing but if a genetic profile had been done good, obviously the targeted therapy is quite possible. That means you have developed a drug which is going to be acting against the responses of the tumor. That is nothing but the mutations. And in case of 2000 level, here we have able to observe vemurafenib. So obviously this is for melanoma condition. So and after that 2017 pembrolizumab. So that has been the most common kind. So followed by larotrectinib. So in these kind of tumors, you might be able to see changes have been happening in post 2018. So this is a significant thing, and a lot of students have been studying about this one called as a next generation sequencing. So you have been using this digital platforms and innovative softwares, and all these are being helpful in identifying a data sets of tumors, and so that you can have a precise, or we can say a tailored therapy for the patient. And we would see in case of 2020 a first tumor agnostic approval, so that is for pembrolizumab has been there. So when this case of pembrolizumab was there, like this pembrolizumab, so it had been usually used for a very long period of time. So this was a very critical concern. So because if one would say pembrolizumab was there, so that would have been a very critical concern for long period. But what made this pembrolizumab a very good drug of choice? So that is nothing but if person was having a high TMB. So this high TMB is nothing but, as we have spoken before, tumor mutational burden. So if as we are speaking, the burden has been increased. From the word you can understand high TMB. So such kind of high TMBs have been usually dealt with this pembrolizumab, and they have been successfully giving the outcomes. So here we would understand very basic details of cancer biology. So it is only nothing but till now we have talked about the biomarkers. Understood based on the presence of biomarkers. How the response of immune therapy could be assessed based on the biomarkers. The biomarkers have nothing but those are your immune response changes with the administration of this immunotherapy. But before that, we would know when we talk about a cancer biology, we would always see how this tumor had progressed, how these changes have occurred. So that is nothing but here you are going to see variations. That's what we say. A tumors would never be the same. So they are going to be a very diverse set of populations. So each kind of tumor has a different kind of genetic compositions. Their mutations are going to be different, and the behavioral pattern is going to be different. So what could be the changes that have been happening? So that is with a proliferative signaling and also evading growth suppressors and resisting cell death, enabling replicative mortality. So we'll be just having this all the flow in one diagram. I'll just show you. And also we are going to see the immune surveillance theory. So that means what happens usually your immune system is like a security, so where it would be acting against these tumor cells, but whereas in certain kind of tumors they will develop. So that means here we can understand a good adaptability happens to evade the detection. So it's just like masking or like changing a costume, so that if somebody had been following someone and all of a sudden they just disappear and change the costume, so they could not be identified that easy. In such way, here we can say that immune surveillance theory denotes this surveillance is going to be failing. So that is nothing but the tumors can masquerade such situations where they can evade the signals through the immune cell. And tumor immune evasion is going to be happening, and it is a very complex process where the first thing happens is it's going to downregulate major histocompatibility molecules. So once if it is like switching off something which is important for the immune regulation, obviously you can see that whatever this secretions are going to be out of balanced. So that means here we can say downregulation of MHC molecules happens first, and after that you can see changes in secretion of immunosuppressive cytokines. So if you are talking about a immunosuppressive cytokines, that means it is downregulation only, and also regulation of regulatory immune components. All these are going to be having a very impactful changes. All these immune cells, where the immune cells have to be regulated, they would undergo a disturbance. So this is a picture I would like to show you, because in previous concerns we have a hallmarks of up to a certain stages, but a new kind of factors have been added. So we would always know usually a tumor is nothing but it would be growing uncontrollably. So that means the growth suppression has to happen in case of a normal cell cycle where it is being evaded in kind of conditions. And also avoiding immune destructions. That means we are saying it is having a shield or it is not prone to the immune activity, and enabling replicative immortality. So as we will say, when we talk about this immortality, so when usually a normal cell is going to divide, it usually has a telomere caps, end of chromosomes. What happens after each repeated cell cycle? The cap is going to be undergoing wear and tear. So once if it is going to be wear and tear till a condition like a very edging condition, so the cell stops dividing. But what happens in case of this tumor cells? These telomere caps are very intact. No matter how many proliferations would they undergo, still they would remain the same. So that is giving them a chance. That means it would not get any kind of a response believing that they should stop the cell cycle. It undergoes a lot of changes after that. And tumor promoting inflammation. So since we are always talking about the inflammatory mediators or inflammatory responses have been happening, likewise we said, even though they are pro-inflammation, we have to remember that pro-inflammatory components being there are going to be actually promoting the tumors. Unlike what we usually make an assumption in case of any infection, a pro-inflammatory mediators are nothing but like they are targeting the infected tissue. They will be just shooting out over to the tissue. They cause a damage, and of course collateral damage happens, and we would be losing a good tissue as well. But here it is not like that. We assume the inflammatory condition to be good enough, but the expectations would turn upside down. Instead of having a positive effect, it is going to be having a much more negative effect, pushing the tumor cells to a greater extent of proliferation. And also, we are going to see a microbiome changes. And the most important thing we are going to observe is genome instability. You see, the instability happens because when we talk about a tumor, we say in a normal circumstance, if a DNA gets damaged, what happens is the cell is just coming out of the cell cycle. It has its DNA repaired. We have a genes for the DNA repair. It's called DNA repairing genes. And also after that thing, it will be again entering into the track. So just like a race car. So while if a race car is undergoing a lap finishes, so at one certain point it will be coming aside and it has its tires replaced, and again it enters into the track. Same thing happens with the cell. But what happens in this condition? The DNA damage would not get repaired, and instead it continues into the cell cycle. There isn't any components which is going to stop it in such condition. So it again multiplies. So reputational damage has already been there. So that would have been multiplying more. So there are more number of cells. So with a damaged DNA, at one certain point, it loses control. So that a proliferation is going to happen uncontrollably. So that's what we say. Tumors are undesired components which are not being required. So here you are going to observe such changes are going to happen. And next thing, the most considerable factor is even invasion and metastasis. So as we know about metastasis traveling from one certain point to the another, so if that is traveling a very farther point, that means it has the capability to grow to a very great extent and to break down and to be traveling in farther directions. How can we say if it could travel to a farther direction? So that will be usually responsible because in case of benign we say it is latched onto the surface, but in case of malignant tumors it has the properties to break down so this matrix, and so that it can disseminate into the stem. Usually we say that lymphocyte, so in case of we are talking about a lymphatic system that is being mostly used. So we are talking into the genomic landscapes because we said that genomic landscapes are going to be the prominent factors. We see mutations are going to happen. So such mutations are being present for somatic mutations, and in somatic mutations you can see, as we said, a DNA damage has been happening. So that could be a driver mutation and a passenger mutation. So that means when we say about a driver and what we can say about a passenger, you can understand if a driver is driving a car, obviously the consequences that has to be met with the car is related to the driver's performance. In the same way, you can able to observe it is driver's mutations are those which can happen and directly leading to the cancer development. So these are a vital part for the cancer to progress. So, and again, particularly here we might be able to see a passenger mutations. So just like we are saying, if a passenger is being present, the passenger themselves are going to be just like a victims of any negative consequences. So that's what here we are saying, that it would not be having a direct role, but here we can say that these are nothing but being present along with the main mutations. So when we are talking about all these changes have been happening, the most common kind of cancer you are going to observe is melanoma. So here we are talking about BRAF, right? So when we are talking about a BRAF, here you can see that it is nothing but a proto-oncogene. So we talk about an oncogenes and proto-oncogenes. Proto means usually I would suggest you to remember like a positive, but not positive in the sense is nothing it's going to do good, but rather here we are going to say that the proto-oncogene is something which is making the cells under control and would not allow for any proliferative or unregulated proliferative conditions. But when if you are removing this proto, the positive nature from an oncogene, so the proto-oncogene, you remove the positivity, it becomes oncogene. So directly here you can see the prefix to be first thing is onco. So in that way, the first thing you're coming across onco cancer. So that means it is driving into the cancerous condition. So another genomic landscape you're going to observe is a change in copy number. So that means here you are going to see the chromosomes if they have been damaged, if there are any multiple copies. So large segments of chromosomes are there. So that kind of undesired, unrequired, or we can say such kind of more proliferations have happened. So that will be leading to the growth of the tissue. So particularly we are talking about a malignant condition. So that's what you can see in case of breast cancer, HER2 amplification and EGFR amplification in glioblastoma. We know with this breast cancer and glioblastoma are very severe cancers. The dire consequences of this, the mortality chances would be higher in these cases. And you might able to see a structural variations. That means structural variations in the sense nothing but you have a whole genome set, but instead of a small pointed changes or mutations, you can see a larger part of variations are going to happen. So one thing is you can see a translocation of the materials. As we've spoken, if you see this uh, part of a chromosome, so if that is being present at the designated area, that would work well. But if that is being translocated, either it undergoes dysfunctional or it goes out of the control. And you can see inversion changes, large insertions, or large segmental deletions. So all these are nothing but it is making this genetic sequence incompatible, and it is disturbing the integrity of the genome. And epigenetic changes. So that means here you can see that epigenetic, here we say that not the genes are being a direct contributor, but there are certain outside factors or the external factors that are going to affect the gene expression. So at certain factors will be there, gene expression is being affected, but DNA sequence remains the same. So such kind of alterations could be DNA methylation, histones. So how they are being coiled, the DNA is being coiled. Histone modifications is going to happen, and in certain cases, the chromatin might become remodeled. So the main important cancer genes you might want to remember, like which can drive the cancer growth, is CRAS, BRAF, PIK3CA. So we have a whole lot of abbreviations for that. And also you have to see for the tumor suppressor genes. You would say, if we have tumor suppressor genes, then how come this cancer is being prevalent? The best thing we can say about tumor suppressing gene is P53. So it's the most prominent tumor suppressing gene, and also retinoblastoma gene. So all these are very good genes. But what happens once if they have become inactivated? So that means they would not have any control over the cell cycle or cyclins or cyclin dependent kinases. So that means they would not have the control over the cell to repair, to modify, and to put it on the right track. So all these are going to be having a very crucial role. So we have been talking about this immunoprofiling, right? So we are going to see, okay, you are making an immunotype classification amongst the cancer patients. Types. From the word we have to understand, okay, we are segregating into types. That means we have a definitive parameters for each type, each immunotype. So that is going to show the immune activity. So you have to identify the immune types. So that is nothing but, particularly you're going to look into the research. So that is nothing but researches are usually done on this multi-parameter flow cytometry. So this is the most prominent kind of method we have been looking into. So you are going to have this peripheral blood taken both from the donors and also from the advanced cancer patients. So what happened is, this data has been corroborated. So that means here we have been able to identify 70,800 open source transcriptomes. So these are being able to identify the filing characteristics. So from one genetic aspects to another genetic aspects, how they are being more immunotype classified. So how you are saying one type is different from another type. So that depends upon the kind of immune cell that is being active. So here you can say natural killer cells were high and T cell activity is low. And in immunotype 2, you can see B cells have become increased and T cell activity has just remained in the moderate levels. And what kind of, what we can say, a predecessor cells are being present? Myeloid cell profile, if that is being more than compared to this lymphocyte profile. So if you are going to see immune profile is good or okay, or else if it is performing well, if it is normal, or if it is just moderate. So if we talk something is moderate, means there is some effect which has already had happened. So there is an influence of the tumor activity. But in case of immunotype 5, here you can see that, because you see, just like how we have been coming from immunotype 1 till immunotype 5, you can see that immune activity has declined, ranging from a good T cell activity to the exhausted T cell phenotype. So that means instead of like being such conditions, you can see only a change has happened with the Treg cells. So that's what we call it as a regulatory T cells. So here you're going to assess the patient. You're going to put one particular gene expression profiles, and each patient, just like how we have a signature that is different from one person to the another, I would say we would have a usually a particular transcriptional signatures. Do you remember, this is not just like a normal signature we are saying. It is just like I could say a watermark. So I could say a watermark, so that is being left by your immune cells. So such kind of transcriptional signatures may happen with each and every kind of immunotype. So that is going to be distinctive from a patient till the patient. So this is being more effective, and it is going to show or going to denote how extent the immune response could happen. So that's what we are saying. Immunotype 1 was good, but when we are coming to the 5, it was poor. So when we say about this cytokine signaling and T cell activation, all these are nothing but here we are saying that immune responses have increased. So those immunotype 1 people could have a better response, but if we are talking about a immunotype 5, so that means here we are saying that it is going to denote a combination immunotherapy approaches. Potential indicator. Why we are saying a potential indicator and for combination immunotherapy? That means you would require a combination. A monotherapy is not sufficient. That means the situation had gone worst. You would require a multiple forms of therapeutic approaches to make it normal. Since we have been talking about this immunotypes and also we mentioned about a signature, there is one component called as a immunotype signature scores. You are scoring. So the scores are usually based on the cell types that are being distributed and the extent of gene expressions have happened. So, but usually this one could be related as a predictive biomarker. So that means as a prognostic level or predictive biomarker. So it is incorporated as one of the component to have an absolute diagnosis. And what could be the patient being experiencing with such kind of conditions? You can see the patients can be usually tailored to one particular therapy. So based on the immunotype, first if you identify the patient, at what category of immunotype does the patient fall into, and if the patient was found to be okay, good with the immune response or very poor with the immune response, would require a monotherapy or should you add on any other combo, or else would be requiring an extreme therapies of all. So these patients are going to be better identified based on the immune responses. So as we can see, immunotypes are not constant. So if what one would fall under one immunotype category, that would not remain the constant all the time. So that means it is going to shift from one to another. So that's what it requires a longitudinal monitoring for a long period of time. So these are the technologies which we are going to see, next generation sequencing technologies. So whole genome sequencing, a very familiar word. So usually we had this entire genome. So that means equivalent to 3 billion base pairs of sequences have happened, and it is going to show all the just like a list of references. The genomic alterations have happened. So here what it can do is, if there is any kind of a non-coding mutations have happened or basic preliminary structural changes have happened, it could be easily detected by this WGS. So when we are talking about an exome, so exomes are going to be focused on protein coding regions. So that means here it is much better than compared to whole genome sequencing, and only which is clinically relevant, those mutations are identified. So target panel sequencing, so that means you had a predefined set. So that means you had done your studies and you have just registered most of the cancer related genes, a predefined set of genes. So that would be usually analyzed and it would be made a comparative analysis. So this would be usually helpful if you are identifying a cancer condition which is quite normal. But what happens in case if there is a rare kind of cancer and if genetic alterations were specific to that cancer, it is of no use, or I would say it is of little use. And the another familiar thing is RNA sequencing. So here it is going to analyze the transcriptomes and it's going to provide gene expression levels. Okay, were there any changes with the genes? Did the gene fuse? And if the fusions have happened, to how much extent? Were there any splicing is nothing but, like, as we are saying, cuts have happened. So any splicing events have happened, or any mutations have happened, or any complemental approaches have happened. All these are usually denoted by this RNA sequencing. And finally, single cell sequencing. So only at the individual cell level, you are identifying a particular histological pattern. Okay, this type of tissue, this cell. So you are going to understand how changes have happened. If that particular tissue had been growing this tumor, how this heterogeneity changes have happened, and it could be only preferred in case of rare cell populations. So I would just give a brief out on all this. In tumor heterogeneity, since now we've been speaking about heterogeneity and heterogeneity, so we are saying, like, this differential changes have been happening. So particularly the gene aspects and how the clone cell has been evaluated. So it will be based on the conditions called mutations, as we spoke, epigenetic changes. So external factors, and so does microenvironment. I said tumor microenvironment is the most important consideration. So here you are going to see spatial heterogeneity and temporal heterogeneity. So that is based upon the genetic profiles. And also you can see clonal evolution, because when we talk about the word clonal evolution, the one thing that comes across our mind is clone cell. So if you are going to see if a tumor has been emanated because of the clonal expansion, that is nothing but, if it is more differentiated, you can expect more genetic elements are being incorporated. So that's what we say, it is more genetically diversified. So that here you can see the selective aspects are there. The most common model you can see is Darwinian model. So that means here you can see that particularly you have been identifying the cells, you have selected that one, and you are elaborating and examining the particular changes in the cell. And branched evolution, so that's what we are talking about, a branched evolution. Here we can say branches. One tree trunk has many branches. So here what happens is, there are different kind of subclones, so that are going to coexist. So here you can understand the environment where different subclones are coexisting is like a trunk of the tree. So from there, different kind of clones have emanated. That is nothing but multiple subclones. All will be there, different clonal cells are there, and they are going to proliferate, and they are going to share a common area. So all these are being helpful to identify what kind of clonal changes have been happening and how much heterogeneity is there with the tumor. So these are going to be the most detection techniques being used: multi-region sequencing, single cell sequencing, as we have said, and also liquid biopsy. It is a very good consideration nowadays in order to detect ctDNA, especially we have told in the previous slides, circulating tumor DNA. So these are all going to be the better implications. So these are required for considering if this particular tumor cells, if it is requiring a multiple targets, so would it be targeting a different responses in a physiological aspect, or else would it be requiring a very truncated therapy? So that will be based upon this detection methods. So this is what we are speaking about, this liquid biopsy. This is usually a non-invasive method. So when you're talking about invasive methods, we would usually take a sample of a tumor. You're extracting from the suspected site, but here it is a non-invasive method. So here you can say, instead, you're going to take out the tumor-derived material. So this tumor-derived material is there going to be in the blood. So you're going to take that sample, and then you're going to identify the ctDNA. If there is any kind of a fragment of DNA released by tumor cells. So here it is nothing but tumor cells. We have to understand one good aspect. We have a normal cell, and the nucleus is 1/5 of size to that of normal cell. But what happens with the tumor cell? The tumor cell has a nucleus, the size which is equivalent to it. That means when we talk about a nucleus of a normal cell, we would expect 1:5 the size, the nucleus to that of the cell size. But when it comes to the tumor cell, it would be 1:1. So that means there is a whole lot of nuclear material. So from that, here you can understand, if you are expecting a many tumor cells have been happening, so that means they have been carrying enough genetic material. And if they have been just like, flung, so here you can see those kind of fragments of DNA could be released. That you are measuring. So here we can say it is a proportional factor. The more that are being present, here you can expect proportionally more number of tumors might also be there. So all these changes and tumor cells circulating, tumor cells could be examined, and exosomes. Exo, I would usually say exit. So that means extra, outside. So extracellular vesicles, which are containing any kind of a nucleic acids or proteins. So those which are present in the vesicles, if they are presenting in the systemic circulation, that could be identified very well. These are all the technologies that are being used, digital PCRs and next generation sequencing. And also we are talking about CTC platforms like, circulating tumor cell platforms. And these are all being utilized in the very main agenda. So you have to detect the cancer as early as possible in order to reduce the risk. And also you have to make a good molecular profile, understand the genetic alterations of the tumor so that you can able to select the treatment approach. So these are all the real-time assessments you can make of tumor burden, and also you have to detect if there is any treatment failure. How would you know if a treatment failure has happening? Obviously, TNM staging, tumor size, number of lymph nodes it had invaded, and also the metastasis. The size has increased, and the number of lymph nodes which are affected by the tumor is going to increase, and so does the metastasis. So here, as being in the pharmacy field, we would also look into the pharmacogenomic aspects. So how you are going to see if your genetic variations are being present. So your response to particular drug is also going to change. But here the concept is what kind of variations, whether if it is attributed to germline or else attributed to somatic variations. Is there any inherited differences or else it had occurred because of the tumor? Because sometimes those there are certain changes which might be genetic or inherited ones, so usually they might evolve in the later stages, and some of those could be occurring only because of tumor. I would say not tumor specific, I would say tumor influenced mutations, so that would be a very better apt one. So in this case we can see pharmacokinetic considerations are being there and pharmacodynamics are there. Need not say everybody would know what it means. And in case if you are looking into the pharmacogenomic aspects, you might be examining the genes. So what changes have happened? So here you are going to observe DPYD variants. That is nothing but dihydropyrimidine dehydrogenase. So that means if these variations in the genes had occurred, and if you are using 5-fluorouracil, so obviously that's going to affect the metabolism. And if there is any deficiency of this gene, so what happens is toxicity is going to increase. And so does here you can see with this UGT1A1 gene. So that is nothing but UDP glucuronosyl transferase. So if that is being present, so what happens is it is more having a risk. So this irinotecan is a different thing because it is not commonly being used. But if you are talking about a clinical significance, you can see neutropenia and diarrhea happens. Neutropenia, decrease in neutrophil count. So when we say always about the neutrophils, those are the first line of defense. We want them at the very first moment. But if you could not have them at the very first moment, your initial immune response would be decline. So that is going to be having a greater consequences. And other genes like CYP2D genes, so particularly it is going to be affecting tamoxifen metabolism. Of course, this drug is not being used for everyone. So particularly this relevance is nothing but it might reduce the efficacy of other indicated drugs. So, and apart from that, here we can see thiopurine methyltransferase and Nudix hydrolase. So all these are being affecting the thiopurines. So that means here what you can see increased risk of myelosuppression. So that is what already the patient had been in deficit. So their immune responses have been disturbed. At such cases, you can see a myelosuppression. So that means nothing but further hampering the immune responses. So that's not good for the patient, and such cases could be observed. So these are the areas where you can able to observe a polygenic risk course. So you are going to examine the many multiple genetic variants, more predictions, and pharmacoepigenomics. Epigenetics, we have been saying that okay, it's not about directly with the genetic material alterations, but have something external factors which is going to be influencing the genetic material. And you want to study if the external factors influencing the genetic response, would they influence the drug response? So that is one question. And in third thing, you can see real-time pharmacogenomic profiling. So point of care genetic testing, because if a person had been with a cancer, like instead of having a period, what I can say, a cooling period for a certain time, you can have an active testing, a genetic testing of the patient in order to know the immunological response. So that would be provided with the immune therapies. So these are all the therapies that could be usually observed as targeted therapies. We know the most significant one is kinase inhibitors. So these are most important classes if you want to have a targeted therapy. So that means here what they are going to do, like we have always been talking about either the genetic material or the proteins being affected. So here the enzymes that are being actually phosphorylating the proteins. So such kind of changes, obviously we would say that as signaling cascades. So that means here we can say those signaling cascades could have an inhibitory role, and certainly the molecules which are binding to the kinase. So if we take the word kinase, we usually understand as a movement. So that means a kinase is nothing but I would remember like as that of kinetics movement. So that means here the activity prevention is going to happen. That is nothing but the cell signaling of the cancer, or we can say the tumor profile, is going to lose. So that means instead of unregulated proliferation, here we can say that the growth is going to be arrested. So that means it may pay for the cell death. So here we can see the examples imatinib, erlotinib, and sunitinib. So these are all very familiar with the pharmacological things, right? And in case of serine threonine kinase inhibitors, we particularly use for target. It is going to target the kinases which are phosphorylating the serine or threonine. We would know the serine and threonine residues are the most familiar ones. So when we are talking about a cell signaling, so such kind of factors are needed to be inhibited. So here we say that vemurafenib and everolimus. So those are good examples. So based upon the target area, whether if it would be a BRAF or mTOR. So there are other kind of an examples where you can see particularly the key approvals have happened. So that is for chronic myeloid leukemia, non-small cell lung cancer, melanoma, breast cancer. A variety of these therapies have been designated. Erlotinib, vemurafenib, crizotinib, ibrutinib, palbociclib. So all these kind of are going to be useful, and particularly targeting which kind of kinases have to be inhibited. So selectivity and specificity. So that is nothing but highly selective inhibitors. If one is highly selective, that means it is targeting a single kinase. And if you are going to say multi-kinase, that means multiple selective. So what happens is if you are multiple selective, that means you are inducing a pharmacological effect on different things. But apart from that, you are going to increase the toxicity. So that is a one kind of thing. So in such cases where you can see second and third generation inhibitors. So that means these usually the later which we have spoken about. So those are going to be helpful. So all these implications have been there, and we can able to even see the CAR T cell therapy. So this CAR T cell therapy is a most innovative approach. So where normal T cells are engineered to produce chimeric antigen receptors. So these are collected from the patient and genetically modified in the lab. And from your T cells, that means it is nothing but giving a training to your T cells and modifying them so that they can be active against the cancer treatment. So these modified T cells as being called as a CAR T cell therapy. So put back into the patient so that they are going to be active against the all these kind of changes have been observed. And I'll be brief with other things like neoantigen based personalized vaccines. These are tumor specific proteins, because if you are seeing a new antigens are being there, so these are nothing but a result of tumor specific proteins occurring from cancer mutations. You're going to observe all these changes. Based on that, you might have a vaccine against this neoantigens such that the burden would be reduced. So these are all nothing but a key findings where they would say that you might be given a vaccine along with this immunotherapy aspects, so that it could be even helpful as a combination therapy. The response rates was very good when compared to be giving alone with the solo therapy. So combination therapy is going to be quite good. It might be even given with the chemotherapy or radiation therapy also. So that's what here we can say. If you are asking me which is going to be the good consideration, I would say neoantigen vaccines are very better thing. So after that, what happened is there was an increase in disease-free survival time. So that means you understand late-stage cancers are usually non-treatable. But at certain aspects also, people have improvised in their health condition. They did not exhibit any kind of a tumor growth. So all these things have happened and would be most beneficial. And in a very concluding aspect, here we can see that epigenetic therapies, as we are speaking a whole lot about epigenetic changes. So these are nothing but here key therapies were there where it is going to be acting along with the immune therapy to stop the cancer growth. So here you have to see, you have to silence. So that means what happens? You have to silence the aggression. That is nothing but tumor suppressor genes were good. But what happened? Somebody had suppressed the tumor suppressor genes. Now you have to I don't mean to say resuppress. What I meant to say that is whoever had suppressed the tumor suppressor genes, now you have to remove the suppression. That is nothing but reactivation. So all these are going to be helpful, and these therapies would have proven to be a very greater extent. Okay. So, with this, I would like to conclude for today's presentation, and I would like to thank for giving me this great opportunity. And I would like to thank all the delegates who have been present over here. I hope this kind of topic would have given any new updates or ideas into the mind. Thank you very much. And if anybody would like to have your questions answered, you just let me know. You can just put it in the box. I could answer it for you. See, there are a plethora of topics that could be discussed in this immunotherapy. I would say if we would proceed with this kind of discussions, it may take even greater than day also. If we look into all the scientific details, there is a lot of complexity that is involved in immunotherapy. So it is, I just reserved it only to a certain extent, and I would like to have any kind of questions to answer. Yeah. Is there any question, sir? I cannot see on my screen.
Any queries?
Yeah, if anybody have any queries, so if you are good with it, then I'll be much more delighted.
Thank you so much, sir, for providing your valuable insights on this current topic.
Okay. Thank you very much. Thank you all for attending over here on this last day of FTP
Our
session.
next section,
Yeah.
session will be starting at 2 p.m. regarding herbal drug industry, presenting by Dr. SNVR Sirisha, ma'am. Thank you, everyone.
Thank you all participants.
So I request our principal, sir, to speak regarding this section.
Interestingly attending all the sessions. I'm very much thankful to all. And let us energize ourselves with all these new topics. Okay. So afternoon we have the last session. So let's all join this. Okay. Thank you.
Okay. So
I request our principal, sir, to speak few words regarding this session, sir.
Hello, all participants. Hope you all enjoyed this session. I think it is useful for all the teachers, not only for the pharmacology, irrespective of specialization. It's a common topic. Cancer is coming like anything. It is spreading like anything. So treatment of cancer and its therapies in the cancer treatment is all very much useful. It's a topic of the present day. Prakash has given very good information about this cancer treatment and about the immunotherapy. All these things. I think all these things are very useful to us. So thank you all participants for your attending this type of session. And afternoon, we're going to have one more session at 2 o'clock. It's the last session for this 5 days session. Okay, FTP. Thank you very much.
Thank you, sir. Thank you, everyone.